In.
Sarah, can you? Oh, there we go. Yeah, I didn't have those up on the
Oh,
screen. You've hit it. Thank you.
we're recording now. We're good. Okay. Welcome, everyone. For any of you who have not seen me speak before, this is very interactive. I try to answer questions as much as I can. I will pause from time to time to see if you guys have questions. Today is a very nutrient dense lecture, so let me say it that way, but a really critically important topic in my practice and the practices of so many of you. And so this is something I'm seeing coming up a lot in my mentorship courses. This is something coming up a lot in Advanced Women's Health. And we also launched Advanced Men's Health this year too. So I brought a fun men's health case just to keep you guys all on your toes. You think I'm predictable until I do that. And so I really want, my goal for you guys today is to come to be able to understand that the difference that we have to provide people is that sometimes they're coming in with what seems like a lifestyle condition, and we actually have to do primary care like right out the gate. We are having to DDX and manage really significant pathology. And so I wanted to be able to have this conversation for you guys to understand how all of these things are connecting, but then also how you can start to break it down in practice. So we are going to dive right in. So as I said, today, I really want you to leave with this understanding of diabetes, prediabetes, fatty liver, and how that's relating to what's happening with respect to kidney function. We don't hear a lot about kidney function in training. I think it's one of those things that it's like, oh, it just either continues to decline or it doesn't, and we'll figure it out later. But there is so much that we can do to help our patients understand risks. We're also going to be talking about some of the advanced liver function tests, C-peptide, which you guys are getting access to soon, which is super exciting because we have that in Ontario, and it's a really important tiebreaker test. And then we're going to dive into cystatin C and ClinRisk and some of these other tests. So I always like to start with connections. So many of you know, I really believe and treat in such a way that there's 5 to 7 causes of disease. That's it. That's all. And it's even funny as I'm like getting into and being asked a lot of questions from like the business perspective. I'm like, there's 5 to 7 functions of a business. So it distills down in a lot of ways, in that we really always need to be focusing on like 2 to 3 of these different aspects to get someone from disease or disease state to wellness. And so this diagram here just represents that connection, right? We see there is a really strong connection between the liver, right? And when we are in this place where there's increased glucose production, we're seeing that a lot right now on CGMs, dyslipidemia, fatty liver, inflammation, that's directly impacting adipose tissue, right? And with that, we're seeing hyperinsulinemia, we're seeing increased inflammation, we're seeing fat spilling out of those adipocytes and affecting the muscle with decreased glucose uptake, affecting the kidneys, right? Affecting vascular health, because the kidneys are really just a microvascular unit. And so we're seeing the gut impacted, the pancreas, and this article, I think, does a really good job of breaking down that kind of nephrology, metabolic to nephrology conversation, but fundamentally that's what we're going to be diving into today as well. So one of the things that I used to say, and for any of you who've heard some of my initial lectures, because I've been lecturing with Life Labs for a really long time, one of the things I used to say is we can kind of assume really big pathology has been ruled out. And that's not true anymore. We are primary care for so many of our patients. People are coming in looking to feel better. They don't know what it looks like, but they're like, I just want to feel better. And we then run sets of labs, we gather data about their bodies, and we can see really progressed dysfunction. And it's silent. And so one of the things that I see as a miss when I'm working with practitioners, when their practices, their retention's not great, they're struggling to get referrals, is they're taking just what that patient says and then treating a symptom. They're not necessarily integrating and getting a deeper understanding of what that patient can't know and can't see, and putting it together and then giving plans that are effective and connected based on that. And so I hope leaving today, you will consider that a little bit differently, because it's a huge miss that we are seeing across the board in many different professions. So before we get into the sexy stuff, we need to cover the basics, right? And as someone who is very much in love with research, but also we see north of 2,500 patients a month at our clinics, I'm very grounded in the fact that the liver is a source of dysfunction in so many cases, whether there is research or not. And the reality is that liver dysfunction exists on a spectrum. And when we're just looking at liver enzymes, we are missing a solid degree of that spectrum, right? We know 20 to 25% of the liver can be fatty before it's called fatty liver. We know that if we use our standard reference ranges, we can miss 25, some studies show 50% of liver dysfunction. We need functional and narrower ranges. We know that the liver is resilient, but when it's hit by inflammation and insulin and fat and a virus all at the same time, then we just get stuck into these cycles of dysfunction. And so it's really important that we understand not just the damage to the liver, because as we'll talk about here in a second, liver enzymes come out when there's damage, but we also are understanding the functional impacts of liver disorders. So when we have those patients with high overnight glucose, that can be a liver dysfunction. When we have patients with ferritin issues and low ceruloplasmin and low transferrin and iron dynamic issues, that can be related to liver function. When we have patients with diarrhea, that can be related to liver function, even when liver enzymes are normal. And so we always need to be factoring that in. And so these liver enzymes, right, when we look at where they're living, ALT, AST, a little bit of GGT, these are living inside the liver cell. So in order for those to get into the bloodstream, the cell needs to rupture and break open, right? And so, whereas when we look beside the cells or between the cells, ALP, part of GGT, these are in between. And so that can be a helpful understanding when you're trying to understand why, one, someone has some liver enzymes that are elevated and some that are not, right? But also why you can have a patient with functional liver issues, but their liver enzymes are not actually elevated. It doesn't mean that they're not at increased risk down the road, but it does mean that they're not getting rupture of those cells. They are getting dysfunction, but not rupture. And so that's just, I find, a key differentiating factor when you're talking to patients, because if you're like, "Oh, okay, well, we've got bile issues, we've got ferritin issues, iron, we have all these challenges." And they're like, "Oh, but my liver enzymes are normal. Like, why would I treat my liver in this situation?" And so it's just helpful, again, to be able to break that down and I think explain it such that your patient now understands, one, that you're the authority in the room, which is so key, but two, why these labs are still very important, because they're telling us something, right? They're telling us there's dysfunction, but not necessarily acute and active damage, which is helpful. So then we've got our liver enzymes here that we're looking at, right? And so when we say narrower ranges, the cutoff in many situations and in many research studies is now looking at a high end of 25. And so we historically were looking and we're like, okay, 30, 35 is normal. 25 does seem to be a range where we're catching more dysfunction than not. When we look at our ALP comes from the placenta, of course, but it also comes from bone. It also comes from intestines. So I had many patients in the menopause world who come in and their ALP jumps as they hit that final year of menopause, or when they're entering final year without a period. And we're saying, okay, you should probably go for a DEXA scan. Like, we need to know what's happening, because your ALP jumping could be related to your gut or your liver for sure. And we're always looking at other liver enzymes, but it could also be a sign of breakdown here. And when we say ALP being lower, 20% of the blood level is the intestinal isoform. Do we have some dysfunction in the intestines. What's happening here? So these panels, and when you understand their ranges, can give you an indication, yes, of liver health and dysfunction, which is very important, but it also helps us look outward, right? When we look at GGT, yes, there's alcohol, there's biliary disruption, right, and obstruction. There's pancreatic challenges, but we also have the glutathione signaling of things and oxidative stress and damage. So even again, looking at a liver panel with a CBC can take us really far in terms of understanding what is happening. We then have, for a complete liver panel, we've got our LDH, right? So again, looking for those breakdown markers. But one of the ones we don't talk about enough, and we use a lot at Advanced Women's Health, is bilirubin. So bilirubin can either be a sign of red blood cell breakdown, or it can be a sign of that kind of greater level of dysfunction in the liver's ability to filter and get rid of bilirubin. So you can see we slowly are just creating this net, which is helping us understand dysfunction. And then when we have our patient's age, right, our CBC, which will give us platelets, and our liver enzymes, so AST and ALT, we then can start to march down the pathway of dysfunction. So this presentation, we're going to go from, okay, you've got a liver panel because you ordered it in Ontario. We ordered the advanced digestion panel, liver digestion panel, which has a CBC in it. And we say, okay, what is happening here? And so FIB4 is a calculation that gives us a general indirect understanding of fibrosis. So it's essentially your age, right, an AST, and then platelet count and the square root of ALT. There's calculators online. It comes in Ontario. It comes calculated already. And then this is the general reference range you're going to get. But what we have seen over time is that there's new proposed cutoffs. So whereas previously, we can see here, we're saying, okay, for low probability, we want it less than 1.3. We're now saying, okay, depending on the age category of the person, because age is definitely a factor, maybe we want that closer to 1 or 1.2, whereas as someone's getting older, they can have a higher level, 1.2 to 1.9. And so this is become the most kind of agreed upon reference, although I do like to see it less than 1.2 myself, especially in that population less than 50. When we're looking less than 35, if there's liver dysfunction and we're concerned about fibrosis, just because age is on the top, we are going to see a false negative. We're going to see it lower than it would be. And so that's when we're going to move towards more of our ELF testing, like we're going to talk about here in a second. When we look at the category of 36 to 65, we likely safely can get some understanding using the traditional reference ranges. Whereas when someone's over 65, that's when we need to be looking at a higher reference range due to the fact that, again, age being higher. And so whenever you get further investigation, that's whenever it's over, again, 1.3 in the case of a traditional, like a 36 to 65, or whenever it's over 2, that's when we're looking and saying, okay, now we need ELF, now we need some kind of biopsy, imaging, et cetera, to understand what's going on. And that takes us to our ELF testing. So enhanced liver fibrosis testing, or ELF testing, is a direct marker of dysfunction. So we've got our liver enzymes, which are saying, is this cell rupturing? Is there some kind of damage here? Then we move through and we say, okay, has that damage progressed to some kind of fibrotic event? And then we say, it potentially did. Let's look at ELF testing. So ELF testing is direct markers. It has been researched hand in hand with biopsy. And we do see for a blood test, it can give you a very significant indication that this patient needs to move forward with further testing. And so it's testing our 3 different markers, right? So we've got our hyaluronic acid, our procollagen, and then our TIMP, right? So tissue inhibitor matrix metalloproteases. So those 3 markers, when used together and calculated, can give us an understanding of how progressed this is, because you'll have patients, they have platelet dysfunction, whether it's age, they've got immunological dysfunction, they have fatty liver. It's kicking their FIB4 up a little bit, especially with insulin resistance, because insulin resistance can cause platelet clumping due to fibrinogen and other factors. So we'll see, okay, this FIB4 is not looking good. And of course, that's so alarming to a patient, right? They're like, I have fibrosis. What's happening? Especially in those patients who have a family history of dysfunction, a family history of non-alcoholic fatty liver disease or metabolic fatty liver disease. And so they're wanting that further information, but to access a biopsy or even imaging is incredibly challenging. So we now have that ability ourselves to run this direct marker to say, okay, directly, when we don't factor in your age and platelets, you have a very low risk of fibrosis. And they can, again, do the work that we're working with them on, but rest assured. Whereas if it comes back moderate or severe, then we're like, okay, these are standard tests. These are not naturopathic tests. This is not like a GI stool test when then the doctor's like, well, if it didn't come up on a life lab stool test, it doesn't matter. These are generally accepted, the same language tests. So if your patient does not have primary care, you can send the FIB4 and send an ELF test and say, this is the data I have. This is why I'm concerned. And this is why I need imaging for this patient. And so it just builds that case on an equal playing field and an equal communication field, which can be so helpful in today's day and age. Any questions about liver function testing before we dive into our kidney testing? Give you guys a minute here. Clear as mud, I guess. Okay. If you guys do have questions, just throw them in because I can answer them as we go. So now let's get into our kidney function testing. So we live in a world, like it or not, where many, not just now a bodybuilder, not just now an armchair athlete, but many a perimenopausal women are coming in hopped up on creatine. And creatine can break down. It doesn't cause dysfunction, but its breakdown product is creatinine. So we can see that show up. And with that, that can cause alarm in some of our patients. There is a label on that bottle that says, do not take if you have kidney disease. I'm not here to tell you about the safety of those things. Personally, I think ATP as a donor is very, very important for kidney function. Mitochondrial health is very important for kidney function, and creatine helps with both of those things. But what you're seeing is not damage to the kidneys. What you are seeing is the byproduct of something you put in your mouth. And so just like, again, you take your B vitamins, your pee is bright yellow. That doesn't mean that your kidneys are dysfunctional. It's just, again, it is a marker that alarms people that we need to be aware of. So this is where, for many reasons, we have other tests. So what you can see here, and I like images just so that, again, you guys can get a bit of a visual and use these things to explain to patients, etc. But when we look, creatinine and cystatin C, which is another marker, right? They are both freely filtered and they're not reabsorbed. So they're freely going, again, between the urine and the blood, which we can see. And so when we're looking, cystatin C is a part of all nucleated cells. So it's just, again, moving back and forth. It's easy to navigate. It is easy to test. But when we look at the differences and when we're looking at where it's important to have different testing options, not just for our creatine lovers, we're looking at the fact that, again, your creatinine can definitely be affected by a variety of things, high or low muscle mass. It can be affected by supplements. It can be affected by certain medications. And it can be a bit secreted. Whereas we see cystatin C is not going to be, it's not secreted and it's not directly impacted by high or low muscle mass. When we see though, the levels can be impacted by inflammation, corticosteroid use, etc. So this is where no one test that we have access to, no one biomarker is perfect. But we are getting more and more of these biomarkers to be able to put together these beautiful pictures and patterns for our patients to understand what's important, where their risks are, and go from there. So, as I said, cystatin C is a small protein. It's produced at a consistent rate, and it is not going to be directly impacted by muscle mass, diet, gender, or race. Whereas when we look, it is, yes, impacted by our adiposity in certain situations. It is impacted by inflammation and corticosteroids. But when you have the two tests together, your EGFR creatinine and your EGFR cystatin, those ratios, when we understand those together, can again build this really consistent pathway for patients. So when you have a patient with really high muscle mass or sarcopenia, which we're seeing a lot, when we have a patient with an EGFR that is low, when we see that there's a discrepancy between your EGFR creatinine and what you think is going on, and then even situations, which again, we're seeing a lot these days with patients who have high or low protein diets. And we're trying to understand, is this marker being impacted by your diet? And I swear to God, the number of like protein shake induced kidney function changes we see, because it depends on what the patient's doing, what's happening over time, what protein powders they're taking, how their body's navigating it. But I have seen patients in a full panic about the decline of their kidney function and with EGFRs like in the 40s. And they are on specific protein powders or a lot of protein powders or dosing, and they're getting a lot of protein. They start to reduce their protein powders. They go back to whole food based protein, and their EGFR goes back up 90, 100 plus. It's all of these things are happening in our offices. And right now, we're just like, okay, let's just repeat your EGFR and fingers crossed, hope for the best. But to be able to now have a lot more tests and a lot more understanding of what's going on helps to rest people assured, because again, reminder, we're primary care, right? And so we need to be able to do this. Limb amputation is another one, right? So depending if you're seeing a lot of veterans, if you're seeing a lot of diabetic patients, these are all things we need to consider. So when we're looking at an elevated level of cystatin C, we're looking at cardiorenal dysfunction, acute kidney injury, any kind of CKD, obstruction, smoking, active malignancy, glucocorticoids, very dysfunctional thyroid, like not in a naturopathic hypothyroidism, but significant dysfunction, very elevated CRP, or a very high adiposity are all potential confounders, which is why we run both, right? And when we're looking at prognostic value, this is where, again, we are coming to understand. You have a patient, they come in with an abnormal EGFR, right? Then you send them and you say, okay, let's get a cystatin C. When we're looking, if we see that there's at least a 30% lower your EGFR to creatinine, that's going to be associated with higher levels of mortality, cardiovascular events, and progression. And so again, now we have this another layer of dysfunction. When there's a discordance between our cystatin C EGFR and a creatinine EGFR, we're saying there's a likely that there's CKD progression. There's a likely of cardiovascular events. We need to run a clin risk, which we'll talk about. We need to do some renal ultrasounds and then see what else. So is there a thyroid dysfunction? Is there an inflammatory dysfunction? What's going on with urinary levels? So your UACR, we're running all of those tests at that point to be able to better understand. Do you stick with a question just came in. Do you stick with the WHO suggested intake of protein, higher, lower, depends on the individual? Great question. So I was talking about this in Victoria and we went on like probably a 20-minute tangent. So I will keep this under control. We have a lot of research on protein intakes. I do not use WHO standards. I have this like big chart summarizing all the research that I have in one of my courses because everyone was asking about protein. So essentially, the gender and the age, the muscle mass and activity are all the big factors. But the healthier someone is, sometimes they don't need as much protein depending on their age, activity, etc. That being said, I'm never doing like 0.8 per gram per kilogram. That's just not enough. So it depends on the individual very much so. We believe in like customized protein intake thresholds. Even like at Advanced Women's Health, we're rolling out in a much bigger way our very strategic use of protein, especially specific amino acids. So again, like I don't use BCAAs, but essential amino acids can be helpful in a variety of populations. So protein is like a whole thing, but it's being oversimplified and overcomplicated at the same time online, which is really frustrating. Hence, I dive into the research to pull things up, but it's a really great question. Okay, so now we're going to dive here into ClinRisk. So ClinRisk is essentially a proprietary machine learning system. And so what that means is we're taking someone's blood, we're taking their urine, and then we are able to analyze and give the patient a very direct report. And so what we can see is what the risk is of a 40% or greater decline in kidney function. And then you get a low, medium, high, and you get Y. And again, you get this beautiful little PDF that will help you to communicate with other providers if we need to move things forward. So this is your BC ClinRisk requisition. It is a separate requisition. That requisition is in handouts. I am just checking right now. So there is a high-risk sample report and there is an ND ClinRisk requisition that is present, and it looks like this. So these are all the tests that need to be run, and the patient should go fast. No, if the patient is fasting, ask them to eat something. Yeah, so we were debating about this in Victoria, Tina. If you want to pop on and give the specific instructions, they need to give their urine same day at the same time. So they need to have consumed water, but not chugged water. And we need to ensure that the patient has something in their system. Is there anything else, Tina, you wanted to comment on?
Yeah, just to give a tip, oftentimes when we want to go out, we always go to the washroom before we leave. So if the Life Labs is close by within 15 minutes, I would just advise the patient to hang on to it. So pee at the lab, because if they can't do that, then the test is not going to go through. So you need to produce both at the lab.
Very good. Thank you. And then this is, because I know some Ontario people might see this, this is what our Ontario ClinRisk panel looks like. If your nurse practitioners are running it or you're working with other allied medical, then that is going to be how it is put into place. So just wanted to have that as a resource for everyone. And then this is what it looks like. So you get this test report. You guys have a copy of it as well, but it shows you, okay, this patient has a high risk of greater than 40% kidney decline. And then it will also tell you the factors, the monitoring. And so this patient had metabolic acidosis. Their carbon dioxide level was high. We want to monitor them 4 times a year. And then nephrology is indicated. And so that will, again, give you this beautiful little package that you can then take to, if something's outside of your scope for next steps, that you can then take to give to a walk-in clinic. You can give to one of these online docs, or you can give to their family doctor so that they have all of the information they need about how to proceed forward. So when we're looking at our albumin to creatinine ratios, again, this is spot urine. And so we want to make sure that when we're ever doing spot urine, we're always considering all the factors that could be in place and what we want to be understanding and taking from that. So as a general rule, right, you can see here, we want less than 30 milligrams per gram, less than 30 milligrams per millimole, and then it increases in severity. So the more albumin spilling in, albumin is a really big compound. The more that's spilling into the urine, the leakier the kidney, the more dysfunction. And so we do not want to see this level going really high. And then this is just your DDX list, right? So if it's high, is this person dehydrated? Do they have really high muscle mass? Do they have a really high protein intake? Again, is there creatine supplementation? Have they just exercised really intensely? And then these are the standards that we see in the research in terms of our median and then our percentiles in either direction. When we're looking at low levels, do they just chug a lot of water at the lab so that they could go pee? Not a good idea, right? Are they sarcopenic? Do they have a really advanced CKD? Is there a liver disease? They're not making albumin, right? Is there malnutrition? They're not making albumin. So these are all the factors that we need to consider when, again, running these tests. And then that takes us to our C-peptide. So C-peptide, as you're rolling through and navigating these patients with their degree of dysfunction, and you're trying to figure out, okay, what's going on with their liver? What's going on with their kidneys? What is the level of oxidative stress dysfunction that is contributing to this? That is where I, myself, and a lot of people I've trained go towards insulin. So many of you have heard about the insulin glucose challenge test. It is a 3 or 4 point test, depending on where you are and how symptomatic the patient is. You go fasting, you drink 75 grams of glucose. Yes, it's not delicious. And then depending half an hour, but definitely 1 hour and 2 hours later, you have your blood taken again, and we're testing your insulin and your glucose. That test is incredibly helpful in many, many of our patients. But when our patients start to have really significant liver dysfunction or kidney dysfunction, C-peptide becomes a really critical marker because insulin is released from the pancreas as proinsulin, and that has to be cut, and it's cut into insulin and C-peptide. And so insulin is being cleared by the liver. So if you have liver dysfunction, you could have a buildup of insulin in the system, right? Same with, for some people, they actually clear insulin really, really quickly. But C-peptide is cleared mainly by the kidneys. And so if you have a patient and they have really high insulin, but they have liver dysfunction, running C-peptide, if their kidneys are functional, can give you an understanding of how much insulin is being released, and therefore how much insulin is the tissue or the whole body exposed to before we're measuring it at the arm. So it's an incredibly helpful marker to understand the depths of the release of insulin. So I've got a variety of just different data points for you here, but fundamentally what we're looking for with our C-peptide is we expect it to be between 300 and 600. And again, in healthy subjects, so some of these studies have come out even more recently to confirm this, we're looking at the mean fasting level being about 370, which is even honestly a little bit lower than some of the other studies that we've seen in the past. So we do know that in that kind of 300 range, we're 350, even sometimes upwards of 400. The assumption is that we're making a normal amount of insulin. But when you see that level very high, we know that that person, whatever is happening with their insulin or not, if their kidney function is intact, then they're making way too much insulin, and they're going to be at the same risk as of insulin resistance, of oxidative stress damage, all of the other things as someone else, even if their insulin is being cleared differently by their liver. Let me know if anyone has questions on that. So we're going to get into our case here. So C-peptide is something we're very fortunate. I've had access to it for a long time. And so because of the level of dysfunction I see with my patients, I run them hand in hand. So I run insulin and my 2-hour insulin glucose challenge test, as you'll see. But then I also will often run C-peptide and sometimes free fatty acids, which you guys don't have access to in PC quite yet, right out the gate, because it builds this beautiful little metabolic picture. And then when you have your liver enzymes and your kidney function on top of it, you get this really great baseline. And then from there, we can spin out and send people back to the labs, depending on what we need, to better understand if that pathology is taking hold and affecting a variety of different tissues. And that's what we're going to see here. Okay, no questions. So this is a 45-year-old male. He came in, primary concern was fatigue. He wasn't losing weight. He went back to the gym, and he was like, I used to go back to the gym and lose a ton of weight and gain muscle, and now I'm not. He had not been to the doctors in a long time. He was like, I'm a healthy dude. His wife had sent him in. And so that was his main thing. He's like, I'm a bit tired and I'm not losing weight. In office, his BP was 134/86, but he claimed that it was normal in other environments when he took it at the gym, etc., and that he was just stressed. So I ran some labs because, again, I had no data. The beautiful thing about treating male patients is sometimes you get a whole story. Sometimes you get very little. This was a patient that I was like, I'm good. I want to make sure I'm healthy. I want to do all the labs I can do. I want to ensure that my testosterone is in its place. I want to, again, understand what my risk factors are, but overall, I feel good. So we see here his white blood cell count is a bit on the low end. So overall, we'd expect this to be closer to 7. It was sitting at 4.3. His red blood cells and his hemoglobin looked good. His MCV was a little bit high though. So again, we're starting to say, okay, what could be going on with B vitamins? What could be going on? Because we see he's making red blood cells, 12.9 is his RDW. He's making them at the right rate. We also see as much as his white blood cell count is low, his monocytes are sitting at 0.5. So from a percentage basis, they're higher. So we're starting to say, okay, there's likely some inflammation in the mix here. We see his iron level was good at 26.6, so not too high. His transferrin was sitting at 2.5, so it was okay. We then see his ferritin was sitting at 570 though, so very high, much higher than we like to see that, but not in this situation, because I get this question all the time. Is this hemochromatosis? Is this something that we need to manage? But his iron is okay. So this is telling us it's likely coming from inflammation in the liver. His homocysteine was elevated as well. So from a BP perspective, now we have an MCV of 94. Homocystine's high. I'm assuming there's a need to manage B vitamin load, methylation status, etc. We then see his glucose level here was sitting at 6.1. His HbA1c was at 5.8, so not ideal. And then his sodium and potassium levels were within normal limits. His carbon dioxide, we just saw how important that was. That was normal. Chloride was normal. Urea, creatine was also normal, or creatinine, sorry, was also normal. But when we're looking, his eGFR was sitting at 71. And so here, right, we can see that there's some other assessments that we can start to do, because that is an abnormally low eGFR for a generally healthy individual. And so then we continued to do our other testing, but we actually repeated this. So we see here his urate level was 489. Urate is a marker of gut bugs and insulin resistance. So together, when we see that climbing, that to me is saying, okay, or that was, I think it was 469. Sorry, mine is a little bit off here. But in either situation, it's high, right? If that's higher than 350 for sure, we're saying, okay, what's going on with insulin? What's going on with gut bugs? There's something happening here that I do not like. And so we were able to identify that. Total protein was good. Albumin was good. So his liver is making what it needs, right? It's making the albumin. It's able to do its job. But we do see, so ferritin's high. So it's making the ferritin, but it's still high. And then we also see that his bilirubin, his total bilirubin is sitting at 15. And so that, again, we want to see that less than 10. And so we're looking and saying, okay, there is some kind of dysfunction, whether that's happening at the spleen, his white blood cells were low, or there's a little bit of dysfunction with liver clearance of bilirubin. We also see his ALP is, again, okay. His GGT is relatively okay, but his ALT and his AST were high. So we go back to that picture, right? And we're looking and we're saying, okay, there's clearly rupture here. There's clearly damage that's happening, but his lactate dehydrogenase not through the roof. So this dysfunction, right? We start to connect these dots. We're saying, okay, well, this dysfunction is clearly related to some blood sugar patterns, because we have that. It's clearly related to some inflammation. We see that his FIB4 was sitting at 1.2-ish. So we're not necessarily very concerned about fibrosis risk, but we're starting to put together the metabolic pieces of the puzzle of, again, a patient who came in being like, nah, I'm just tired. Everything's fine, but I'm just tired, right? Then we get to the lipid panel. So there's something called uremic dyslipidemia. And so uremic dyslipidemia essentially is a fancy way of saying when you get a high level of HDL, it can start to deposit on the HDL. When you get a high level of triglycerides, sorry, it starts to deposit on HDL, and then HDL can be cleared at the kidneys. So when we're talking about low HDL being a sign of glucose intolerance, we hear that all the time, right? Yes, there's a component of the way HDL is recycled at the level of the liver. We obviously know LDL is made, insulin triggers or stimulates HMG-CoA reductase, right? The same enzyme that is blocked by statins. And so we see that increase in LDL, but the drop in HDL can be liver dysfunction, but it can also be related to the kidneys. So uremic dyslipidemia is something, it's a DDX that I often see missed. And it's one that, again, you're going to have to treat differently, because whether we're spilling HDL, whether we're clearing HDL, obviously clearing triglycerides is important. But we'll talk about when we're trying to get HDL levels back up, we say, okay, niacin, exercise, low carb, and you'll see LDL lower in some of these patients, especially with kidney dysfunction. You'll see the LDL drops down, we see things improve, but the HDL and triglycerides drop down, but HDL doesn't creep up the way we expect it to. So that's yet another sign. Maybe you need to dig deeper into kidney function to see if there's something else going on. So just a little clinical pearl I don't hear talked about very much, but a very important thing to look for. Interestingly enough, in this patient situation, his CRP was less than 0.5. And so when we're looking, CRP is one type of inflammation, right? It's a metabolic type of inflammation. C-reactive protein is made by the liver, and in response to a variety of different triggers. But when we start to see these disconnects, right, between ESR and CRP, when we start to see signs of inflammation, and can I pull up my slide sorter? Hold on. I don't want to make you guys sick here, but I think I just want to go back to my ESR here for a sec. My ESR wasn't on here. Okay, his ESR was high. I was like, I swear I had a number for you guys there. But we see this discrepancy, right? So this patient clearly has inflammation in their body. It's just not showing up there. So we start to be able to pick and pull apart the different pieces. Vitamin D is also low. And again, keep in mind, the kidney is involved with vitamin D, that 25, 125. And so is this something that we need to test both of them when a patient has kidney dysfunction? These are all the questions we start asking. TSH is sitting at 0.52, so that was okay. Oh, there's his ESR. I knew it was here. So his ESR was sitting at 39. We see C-peptide very high, right? We said 370s are ideal, so over 2,000. And then we see this insulin glucose challenge test was wicked. So we want to see our insulin, less than 50 fasting, go up to less than 500, less than 400, and then less than 220. So this relatively healthy patient, as he said, who is tired, has now become a very insulin resistant patient, right? We can see in this test, his fasting level was sitting at 6.4, PAS was 6.1. So his HbA1c was elevated at 5.8. So clearly he doesn't eat 75 grams of sugar per meal, because he's able to maintain his blood sugar better than he was in real life, better than he was in an artificial created situation. But definitely lots of insulin resistance. We've got inflammation. And so we're starting to put this puzzle together for a patient who has very severe risk factors now, right? This patient is going to very quickly become pre-diabetic, if not already there, depending on the environment, right? This patient is very inflamed, homocysteine levels being high, liver enzymes high. So we have a lot of work to do here. We see, again, our patients always want to test those androgens. So we can see in this situation, LH was normal. Morning cortisol, though, so this was 9 a.m., so it's a bit later than I like to see it, but still was sitting at 197, so low. We want that like 450. And so when we start to see liver dysfunction, we can see a suppression of cortisol. Obviously, we can see a suppression of cortisol with chronic inflammation. We can see it with chronic stress responses. But again, this pattern is putting together, and cortisol dampens the immune response. So now this patient has inflammation that's spinning, and they don't necessarily have that cortisol to come put that fire out. Estradiol was sitting at 99, which is okay. DHEA is actually, I would call this low for a male in his age category. So again, playing into chronic inflammation, chronic stressors, and then testosterone levels were relatively okay. Like, yes, we could see them higher, but in the grand scheme of things, with that much metabolic dysfunction, it was not my target. I then followed up because, again, this patient had started a bit of treatment before doing the follow-up labs, but I wanted to understand what was going on from a kidney function perspective. So this is where, again, different labs show up with different things, which is helpful to look at. So his glucose random was sitting at 6.2 with these labs. Again, very stable: chloride, carbon dioxide, urea. His creatinine was stable. His EGFR was still sitting at that 70 mark. Then we see bilirubin had dropped a little bit. Liver enzymes had dropped. So treatment is starting to work, which is good. But we referred out so we can see, again, you've got a clin risk, and then I also did our cystatin C. So at the lab where they did the cystatin C, we also see an even lower EGFR. So these are all, again, very important things to look at. I've never seen it come back higher or normal, but this patient does have a slightly elevated cystatin C. And we are also, again, seeing that EGFR even lower. The overall, when we see his creatinine, his urinary creatinine to albumin, it is, so it's sitting less than that 3 milligrams per millimole, which is ideal. We do see, again, a little bit of that creatinine spilling in, but our spot test there. And this patient had no CKD risks associated. So the risk of him progressing towards that chronic kidney dysfunction to see more than a 40% decline was low. And so this, again, gives us that reassurance. There's something going on in your kidney, something that we do not like. You are very insulin resistant. You have that inflammation. But in this moment, I do not need to make a snap referral to nephrology to assess you for CKD. I can take 3 months. I can take 6 months. I can do the work that I need to do for the rest of your health to then be able to retest and understand if your kidney function has improved, which 9 times out of 10, it will. What levels do you like to see? I run 8 a.m. cortisol, so long as someone, about 2 hours after they wake up. So long as someone is waking somewhere between 6 and 7, then I'll get it run like 8:30 in that range. And I like to see it right around 4:50. So a lot of the research is done on shift workers. They will do it around 10:30 in the morning when you look at their studies, and they often do see a lower level. Why they pick that time, I'm not sure. I personally don't test shift workers very often, just because I do find that the results you get, if you test 3 times, you'll probably get 3 different numbers just because of the amount of dysfunction. But it's a great question. So then we see, again, the rest of this profile is here. So it tells you all about the clinical validity. So again, if you're sending it to a provider and you're asking for a referral, all of the information is built right in, and it tells them about the risks. And then again, when we're seeing predicted risk versus actual risk. So it's all just this kind of one-stop PDF referral that allows us that opportunity to pass that patient through. So you guys always want to know how I treated this patient. So that's what we're going to do for our last few minutes. And if you guys have questions, feel free to throw them in the chat. But fundamentally, whether we're looking at kidney function, they'll say, okay, just let it go until dialysis. Like, what is there to do, right? Obviously, if there's hypertension, if there's diabetes, they'll treat those things. But the kidney is a microfiltration unit. We've seen in the last few years more microclotting disorders. We have seen more mitochondrial dysfunction and damage. We are seeing more kidney issues. I, hands down, am seeing more kidney issues walk into my practice than I ever thought I would, as someone who does not function on, like, treat kidney function. We are seeing more POTS. We're seeing more blood volume disorders. We're seeing a lot of these patterns that are showing up. And so understanding kidney function is a critical piece of that puzzle. But the treatment is in our office. We need to be the ones doing the mitochondrial support, the antioxidant support. If there are concerns about clotting, we need to be doing that, right? We are oftentimes, at least I'm finding these days, we're the ones diagnosing the hypertension. It's if someone is willing to go to the doctor and they have a doctor, that's great. But so many patients are just checking in virtually with their doctors. They're not following up. They're not doing their tests. We have people come in with headaches. And I'm like, what's your blood pressure? And they're like, I have no idea. It's been a decade since it's been taken. So these things are in our office. So too is diet, right? We know that until the updated research is until you have more advanced stages of kidney dysfunction, we should not be restricting protein. But we should absolutely be eating low insulin demand. We should work with our patients and work with their insulin glucose challenge test to understand, does this patient benefit from 16/8 fasting? Should they be doing the fasting mimicking diet? Like, what do we need to do to reduce oxidative stress, reduce damage, reduce blood sugar, reduce the amount of fat in the liver? Because again, when we have more fat in the liver, more liver dysfunction, fibrosis or not, right? Then we are going to see more changes to insulin. We're going to see changes to our hormone metabolism, changes to our cortisol, changes to our thyroid, all of that. Okay. And then from there, we're then going to see worsening of cellular energy processes. We're going to see changes in blood pressure. We're going to see that's all affecting the kidney. We go back to our first diagram, right? Everything is connected here. But the challenge is it doesn't work to just have like a whack-a-mole approach where you're like, okay, one prescription for this, one for this. We need to zoom out. And so when we're looking at this, in this patient situation, he did low insulin demand. We did fasting. Vitamin D deficiency. So in this combination, a combination of injections and oral. Vitamin E, right? So if you're doing the pure tocotrienols, I can't say that today. My team's going to make fun of me because I always make fun of them for how they say things. You're doing about 300 milligrams. If you're doing mixed tocopherols, then you're doing 800 IUs. We're looking at least 300 milligrams of CoQ10. And then in this patient situation, I also used the homocysteine supreme to lower homocysteine, support B vitamins. I used liver gallbladder complex. Those are both designed for health products. I did 2 cups BID. And then that was our first. So antioxidants, mitochondrial support. We started to correct the deficiencies in methylation, start to support cardiovascular risk. And then we're looking at liver support. Okay, open up the pathway, change the diet. Then we worked with antimicrobials, right? So berberine containing antimicrobials are my favorite in this situation. There's a variety of them that are good, and I actually ended up having to swap. But you can see, so he was already on the first part of this protocol before antimicrobials between visits, between those sets of labs, because it took him, I think it was about 3 weeks before when he left my office with supplements to go repeat labs. So you can already see that liver dysfunction improving, which is really cool. And then glutathione is something that if you have access to IVs, IV glutathione it's becoming a lot more popular in kidney dysfunction. And there's a lot of people I respect a lot who do a lot of IV glutathione. I personally don't do IVs, so I can't speak to the efficacy of that, but I do oral glutathione to be able to support oxidative damage, stress, because again, kidneys, microfiltration, very sensitive to oxidative stress and damage. And then we switched the patient from just CoQ10 to mitochondrial support in general, help with cortisol, help with oxidative stress and load. And again, just really helping to holistically put back this piece of the puzzle, because diet is a big piece, right? Diet is a really critical piece. But when we get fat in the liver, we need that mitochondrial support to process it. When we have all that oxidative damage, we need our CoQ10s, we need our vitamin E's, right? We need our liver antioxidants, we need our glutathione. When blood sugar is that dysregulated, we need to treat the gut, right? We need to have pancreatic support and make sure there's no fatty pancreas. And so we are able to put together these pieces so that, yes, the patient feels better in a month to 6 weeks, but you're able to, within a 6-month period of time, make really big changes to the trajectory of the rest of their life, which is something that is so, so powerful. So if you guys have any questions, you can start to, I use the BioClinic mitochondrial support powder. That's the one I referred to here. That was just one of the questions. If you guys have any questions, feel free to throw them in the chat. But if you guys want to get more information, hear more about complex case management and protocols, Life Labs is a sponsor of my In the Treatment Room platform. And so they are offering you guys 30 days free. This is where we take one case with 4 different doctors and we really start to break down the nuances of how people treat, how successful doctors are operating, what questions we're asking, what tests we're running, this is not CE time. So what actual protocols are patients leaving with? So then you get a behind the scenes look from some of the smartest people I know. So it has been so much fun recording that, and you guys get access for free. After that, it's only $10. And from that, one of the things that's become really, really clear is some of the most successful docs have frameworks. They create treatment frameworks, they create business frameworks. And it's a lot of the stuff that I talk about on the back end that we are talking about in some of these live calls on the treatment room, but also we talk about a lot outside, like before we record and after we record. And so this summer, I have some accelerators that are focused on creating those frameworks, whether that's business or leadership or treatment frameworks. So you guys can reach out to me and I'm happy to send you information on that because it is such a key to running 11 clinics and to also keeping patients in the best health is just not having to start from scratch every single day with every single visit. So
thank you, Sarah. This is lovely. I hope everybody found that, it's always nice to have something new in our wheelhouse as we move along. And it's always nice to have you, Sarah, talking not only for Ontario, but for BC. Just for everybody else to take a few moments, you might be thinking about things. So we'll wait a couple minutes, but I'm going to make some comments about some things about the requisition. Just one more thing, Pearl, I do want to share. Sometimes some people want to, if they've done a fasting test on their requisition and want to know when can I use this, ClinRisk because they shouldn't be fasting, and you want to try to avoid the double doc fee. You just want to make sure that they go and eat and have food within a couple of hours. My one also, Pearl, I want to say with going back and running the test, don't try to have them gobble the food within 15 minutes or less, because it's not going to show up properly and it's going to be a rejection as well. So you really just want to make sure you've eaten and there's something in the system within a couple of hours afterwards on the same day of collection from a fasting.
perfect. Did you talk to the person who did it to see if there was an optimal food composition? We were talking about that in Victoria.
No, I know it was an actual practitioner and they were rushing to work, and we know that didn't work for that particular person, and we just know.
Okay. It would be so interesting just to hear if there is because I know when I used to do research back in the day, we would have as awful as it is, our standard awful meal was orange juice and a McMuffin thing, right? It was disgusting. And so patients would eat the exact same thing every time and then do their labs to test dysfunction. And so I know sometimes they have a research standard for what they want the patient to eat, but yeah.
Not in this case. No,
Okay.
Good question though. Yeah. You're always thinking. Anyways, we want to say thank you to everyone again for 1 second here. If anybody has any questions, thinking, thoughts, this is a good time to chat one more time. I'm just going to check and see if there's anything on this chat. Sometimes we have more than one chat, so I just want to make sure. Lovely.
I think we're good.
I think we are good. Thank you so much. We look forward to having you again, Sarah.
Thank you. Thank you. Have a good day, everyone.
Thank you, everyone. Bye now.
Bye.